Hi, so this is going to be part two and an approach to chest pain. I'll specifically be talking about acute aortic syndromes. So this was the general approach that I had proposed in the first video in this series. The first step was to rule out an acute aortic syndrome or a pneumothorax. If it was possible, we would then go in for contrast enhanced imaging of the abdomen and or thoracic aorta. In case of pneumothorax, that is relatively apparent on routine physical examination as well as with a chest X-ray, and that is something that we'll come to in the next video in this series. So in this particular video, I'll talk about the mechanisms underlying acute dissection, aortic dissection. We'll talk about aortic plaques with or without ulceration, penetrating atherosclerotic ulcers, often abbreviated as PAUs, intramural hematomas, which may or may not be associated with a PAU, ascending aortic aneurysms, and how they cause aortic dissections. We'll compare the clinical presentations of an aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcers. We'll reduce the outcomes of luminal compression due to aortic dissection. We'll understand how the causes of descending aortic aneurysms are completely different from those that affect the ascending aorta. And finally, we'll compare the clinical presentations of ascending versus descending aortic aneurysms. So the three aortic syndromes are aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcers. We must first understand the basic mechanisms that underlie the acute aortic syndromes. So this is the aorta. The schematic shows the intima in purple, the media in white, and the adventitia in green. These are the three layers of the aorta. Now, when you get a dissection, this is what happens. This is the direction of blood flow. So, because of increased pressure and due to some kind of damage to the endothelium here, there is a flap that is raised and blood then forces its way under the endothelium. And this is what is called an aortic dissection. The consequences of aortic atherosclerosis are as follows. So, we can just get an atherosclerotic plaque within the aorta. That atherosclerotic plaque can get ulcerated, but that ulceration need not extend even beneath the or within the media. So, this is called an ulcerated atherosclerotic plaque. Then we have penetrating atherosclerotic ulcers and intramural hematomas. So if the ulceration within the atherosclerotic ulcer extends to the media, that is then called a penetrating atherosclerotic ulcer. That can result in bleeding into the media, which is then called a penetrating atherosclerotic ulcer with an intramural hematoma. And then we can have isolated intramural hematomas. This is usually due to rupture of a vasa vessel, that is the blood vessels that supply the media of the aorta. Now, penetrating atherosclerotic ulcers have a variable prognosis, but can in some cases even produce dissections and pseudoaneurysms. So a PAU may compromise aortic intimal, that is endothelial continuity, leading to a dissection, and it may extend so deep that it extends underneath the adventitia, as you can see with the outpouching here, resulting in a pseudoaneurysms. Coming to aortic aneurysms and how they can cause aortic dissections. An aortic dissection is always the result of weakening of the aortic wall. Over a period of time, the same causes that lead to aortic root dilatation, that is aortic aneurysms, can lead to aortic dissections. The most often talked about causes are spondyloarthritis associated aortic aneurysms, and these develop only with prolonged disease due to fibrosis in the wall of the vessel affected. Most commonly, this is with ankylosing spondylitis. However, epidemiologically speaking, the most common cause of aortic aneurysms is either idiopathic or it is cystic medial degeneration. So in case of aortic syndromes, where you have no apparent cause, the risk factors for aortic root dilatation are, I abbreviate them using the mnemonic MACHO, M standing for males, A standing for increase in age, C for cigarette smoking, H for hypertension, and O for is over the top LDL. Among the inflammatory causes of aortic root dilatation, we have Reiter's, that is reactive arthritis, relapsing polychondritis, ankylosing spondylitis, and psoriatic arthritis. Of these, as I've said, Reiter's, ankylosing spondylitis, and psoriatic arthritis would naturally be spondyloarthritis, and here the root dilatation is due to the fibrosis of the wall of the aorta. Similarly, the case in inflammatory bowel disease is also due to fibrosis of the root of the aorta. In all four cases, the pathology develops or the root dilation occurs very late in disease, often in ankylosing spondylitis, taking up to 30 years after initial diagnosis of ankylosing spondylitis. The whys and hows we'll discuss when we talk about ankylosing spondylitis pathogenesis. On the other hand, in relapsing polychondritis, the involvement of the root is a direct inflammatory process that is part of the cartilage inflammation that you get in relapsing polychondritis. Similarly, in Behçet's disease as well as Cogan syndrome, both of which are large vessel vasculitides, you get direct inflammation of the aorta starting within the media of the aorta in case of Behçet's disease and Cogan syndrome. And finally, the most common two large vessel vasculitids that cause aortic root dilatation are giant cell arteritis and Takayasu aortoarteritis. And these are naturally the most common diseases that occur. These are mutually exclusive in terms of the age at which the patients present, although with present criteria, there is a slight overlap. Now, in addition to this, we have mediastinal fibrosis in IgG4 related disease, but notably the inflammation here extends beyond the adventitia, and we'll try to see this during imaging of IgG4 related disease. Now, like I said, cystic medial degeneration is actually the most common cause of aortic root dilatation. It can be isolated, in which case it is then called idiopathic. Cystic medial degeneration is actually a histopathological term, not strictly a clinical term. So often until the aorta has been root has been excised, we do not know whether it is cystic medial degeneration or not. Either way, inherited connective tissue disorders like osteogenesis imperfecta, Marfan syndrome, Ehlers-Danlos syndrome, and Loeys-Dietz syndrome, we get cystic medial degeneration as part of the disease. Then systemic hypertension in isolation and annulo-aortic ectasia, which is a abnormal structure of the aorta during its development, also cause aortic root dilatation. Syphilitic aortic aneurysms are very rare in the post-antibiotic era, but syphilitic aneurysms affect the ascending aorta, and this is important because it affects the leaflets of the aortic valves. This results in ostial stenosis of the ostia of the coronary arteries, and that can cause chronic stable angina. Similar coronary ostial stenosis can also occur in atherosclerosis or arteriosclerosis, which is actually the most common cause. In Takayasu aortoarteritis, we get ostial stenosis, although this is not very common, and in Behçet's disease as well, we can get ostial stenosis. Now, isolated ascending aortic aneurysms may occur as a result of isolated root dilatation with two genetic associations. That is, one, abnormal TGF beta signaling due to mutations in TGF beta 2 as well as SMAD3. Notably, this is not the receptor, this is the protein itself. Second is abnormal smooth muscle functioning due to mutations in MYC11 and MYLK. That would be myosin light chain kinase. So let's compare the clinical presentations of the three acute aortic syndromes. So we have aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. In terms of causes, as we've seen, any cause of weakened aortic wall can cause an aortic aneurysm and a dissection. So in a case of an intramural hematoma, we have the rupture of a vasa vasorum. In case of a penetrating atherosclerotic ulcer, the atherosclerotic plaque tends to rupture into the media, as we've seen in the initial slides in this screencast. Now, precipitants in case of an aortic dissection are one, a rapid increase in LV stroke volume, and two, something that I don't really see, that is trauma due to deceleration injury. There are no clear precipitants for an intramural hematoma or a penetrating atherosclerotic ulcer. These are usually detected on imaging. Now, the most common site of a aortic dissection is either the ascending aorta, in which case it is in the right lateral wall of the ascending aorta because of the direction of the jet of blood that arises from the left ventricle and enters into the aorta. In case of the descending aorta, the most common cause is actually below the ligamentum arteriosum because that is where the aorta is attached to the posterior chest wall, and this is the most common cause in case of traumatic aortic dissections resulting from deceleration injuries. The most common site of an intramural hematoma is the descending thoracic aorta, and the most common site of a penetrating atherosclerotic ulcer is actually the middle or distal descending aorta, primarily because of the amount of atherosclerosis that accumulates there. Intramural hematomas and penetrating atherosclerotic ulcers thus affect the descending thoracic aorta and the abdominal aorta preferentially. The three aortic syndromes can clinically be very difficult to differentiate from each other, and they have 5 typical presentations. The first is a sudden onset of severe tearing pain, which is maximum at onset and can reduce, but a reduction in pain intensity is actually not a good prognostic sign as it often indicates that there is a rupture. The pain localizes variably to the front or the back of the midline of the patient, depending on which part of the aorta is affected, and is referred to the interscapular region. It extends as the lesion extends. So the patient is often able to tell you that the pain is, changing in location and increasing in intensity. The second presentation is due to luminal compromise, resulting in a decrease in the perfusion of the distal organ supplied by the branches of the aorta. So this can result most prominently in syncope or weakness, that is a type of stroke or a TIA in patients who have involvement of the carotid arteries. Third, there can be compression of adjacent structures. So let's see what adjacent structures can be compressed. In case of the ascending aorta, the first thing that can be affected is the aortic valves. Aortic valve involvement results in acute aortic dissection. This is often due to a circumferential tear that causes dilatation of the aortic root. Second, the superior vena cava is affected, causing a superior vena cava syndrome. Third, the stellate ganglion, again posterior in the medial sternum, can be affected, resulting in Horner syndrome. The esophagus can be affected, resulting in dysphagia. This would be a structural esophageal dysphagia. Then the primary bronchi can be affected, causing cough and dyspnea, and can, in severe cases, also cause collapse of the lung there. Compression of pleural lymphatics results in a pleural effusion, which is most commonly seen on the left side rather than the right side because of the location of the aorta, the descending thoracic aorta within the mediastinum. Luminal compromise within a direct branch of the aorta can also be very telling. So the fourth presentation is due to compromise of the lumens of the branches of the aorta. First being the carotid, as I said, it can result in a syncope, it can result in TIA, it can result in a cerebrovascular accident, that is a stroke. The artery of Edenkiewicz, which results in paraparesis because of ischemic myelitis. Then the coronary arteries resulting in angina, but very rarely progressing to MI. But this would be a acute aortic syndrome presenting with acute coronary syndrome. Then renal arteries resulting in hypertension, often refractory hypertension and or hematuria. Finally, we have mesenteric involvement, mesenteric artery involvement results in mesenteric ischemia. It will be acute mesenteric ischemia with an obstruction. So in case of hematuria in renal artery involvement, the reason is actually distal embolization into the glomeruli rather than rupture of the vessel directly into any part of the kidney. But that can also happen, particularly if there is a rupture into the calyceal system. The fifth complication is cardiac tamponade, which we'll deal with separately during our discussions on approach to shock. The mechanisms that lead to descending aortic aneurysms are actually completely different. We're talking about descending aortic aneurysms, so that means thoracic and or abdominal aneurysms. Both are most commonly caused by atherosclerosis, and in the past were also caused by infections. So the infections that affect the aorta can be of three types. You could have mycotic aneurysms, that is basically due to bacterial infection. You could have tubercular, that is mycobacterial infection, and you could have syphilitic involvement. So in case of mycotic aneurysms, the involvement is of the suprarenal abdominal aorta. This is very important. The most common site of tubercular involvement is thoracic aorta. So it will become evident why that is the case just subsequently. The most common site of syphilitic involvement is ascending thoracic and arch of aorta. The type of involvement is on imaging. Typically in mycotic and tubercular involvement, there is a particular site that is affected, and therefore the vessel wall integrity is affected at a very specific site, resulting in a small neck and a large aneurysm, which is what we call a saccular aneurysm. In case of syphilitic involvement, you can have both saccular and fusiform. So fusiform will be a gradual tapering enlargement of the aorta. The mode of spread of mycotic aneurysms is through hematogenous spread most commonly. With tubercular, we have direct spread from a local caseating mediastinal lymph node. And finally, for syphilitic, it is again hematogenous. Now, let's just finish it off by comparing the clinical features of ascending aorta, descending thoracic aorta, as well as the descending abdominal aortic aneurysms. So the general principles that differentiate them are based on the anatomical location of these particular aneurysms, and therefore the complications affect different structures. The most common cause of ascending aortic aneurysms, as I've discussed, is a cystic medial degeneration, but naturally that would require a histopath to confirm. For abdominal aortic aneurysms and descending thoracic aortic aneurysms, the most common cause is atherosclerosis. And as we've discussed, descending abdominal aortic aneurysms most commonly affect the infrarenal abdominal aorta. The clinical presentation of an ascending aortic aneurysm is that of aortic regurgitation, which can be acute decompensated heart failure if the aneurysm is associated with a circumferential dissection and resulting in acute AR, or it could be heart failure with reduced ejection fraction. In case of descending thoracic aneurysms, the only presentation is chest pain. In case of descending abdominal aortic aneurysms, the patients are usually asymptomatic, but when they are symptomatic, they have strong abdominal pulsations, and less commonly they have abdominal pain. The complications of all aneurysms is rupture. The rupture of the ascending aortic aneurysms can cause cardiac tamponade. It can naturally also cause all of the local compression complications due to compressions that I had described earlier. So examples would be superior vena cava obstruction, acute decompensated heart failure, pulmonary edema, and heart failure with reduced ejection fraction. The descending thoracic aorta, the symptoms are due to compression of nearby structures. So I'll come to that subsequently. And in case of the descending abdominal aorta, the complications are usually due to embolization to distal vessels, particularly the renal and the mesenteric arteries. Now, when it comes to rupture, the risk factors are directly related to size of vessel because of the Laplace function. The larger the internal diameter, the more surface tension develops and more the risk of rupture in the wall for a given intramural pressure. So because of that, in case of the ascending and descending thoracic aorta, the cutoffs for risk of rupture are less than 4 centimeters, resulting in 2 to 3% risk of rupture, whereas more than 6 centimeters, resulting in a 7% risk of rupture. In case of the descending abdominal aorta, the side cutoffs are slightly different. We have less than 5 centimeters with a risk of 1 to 2%, more than 5 centimeters with a risk of 20 to 40%. So more than 5 centimeter lesions affecting the descending abdominal aorta are the most likely to rupture. Again, in ascending aortic aneurysms, pain can be a marker of impending rupture. Similarly, in descending abdominal aortic aneurysms, pain can be a marker of descending rupture. The same one-to-one association is not there with descending thoracic aortic aneurysms. So in this discussion, we've covered the following topics. We've understood the mechanism underlying aortic dissections. We've talked about aortic plaques and how they cause ulceration. Talked about a penetrating atherosclerotic ulcer, intramural hematomas with or without penetrating atherosclerotic ulcers, ascending aortic aneurysms as a cause of aortic dissection. We've compared the clinical presentations of aortic dissections, intramural hematomas, and penetrating atherosclerotic ulcers. We've reduced the outcomes of luminal compromise based on our understanding of anatomy of the aorta. And we've understood how the causes of the descending aortic aneurysm are completely different from those affecting the ascending aorta. And finally, because they are often conflated together in imaging, we've also talked about the clinical presentations of the ascending and descending aortic aneurysms. So thank you, and I'll see you in the next video in this series where I'll be talking about the imaging of acute aortic syndromes.